Hi, and welcome back to our newest edition of the Medical Minute. Today, we are excited because we are celebrating World Lung Cancer Day. And so we are going to be talking about some of the newest updates that came out of ASCO this year that are kind of game-changing for our lung cancer patients. But first, I wanted to make it a priority. If you have been with us watching our Medical Minutes since its inception, you would know that at the very beginning, we were really pushing to increase our numbers of subscribers. And at that time, I was promised if we hit a certain number of subscribers that I would be gifted with a tiara to wear during our Medical Minute episodes.
And then when we reach 1,000, I'm going to wear a tux.
That would be fabulous. Can I do an evening gown? That would be amazing. Can I have a tiara?
Oh, I think you must have a tiara.
Video evidence.
We have video evidence, exactly. And so, of course, I had to find out exactly how many subscribers we had because you cannot promise a girl a tiara and then, take it back. And so we are currently at 880 subscribers. So I am so close for the goal. So, not that it isn't important to spread the word about a lot of the topics that we're talking about, but, it's a tiara.
Tiara is a tiara.
Exactly.
Yes.
So, with me today are my co-hosts. I have Andy Guinigundo, who is one of our other nurse practitioners here at Cincinnati Cancer Advisors, and, of course, our world-renowned Dr. Jazieh.
Thank you for having me.
Thanks,
Yes.
guys. So both of you were at ASCO this year, and both of you do have a focus in lung cancer. Can you talk to me a little bit about the LAURA trial and the data that came out regarding that at the meeting?
You want to start, Dr.
Yeah,
Jazieh?
okay, sure. Thank you very much for having me. So actually, it's very exciting news happened in ASCO, but let's go ahead and talk about lung cancer in brief. So lung cancers are divided into small cell and non-small cell. And the category of small cell divided into two major categories, adenocarcinoma and squamous cell and other cancers. So then the first thing we try to look what type of lung cancer the patient has. Then after that, we'll try to look at the stage because the treatment is stage dependent. So adenocarcinoma is actually the type of lung cancer that we can find the mutations that we will be talking about it pertinent to the discussion today. So lung cancer come in stages, stage 1, 2, 3, 4. In the past, we figured out what to do with the patients who had mutations, the EGFR mutation, which we are going to talk about today. If it was stage 4, we know what to do with it. We have medications to treat these patients if they have the mutation. Now, even for stage 1B, 2, and some of the 3, we also, if the patient underwent surgery, the treatment for earlier stage is surgery, and they have the mutation, then we give them the osimertinib, the target therapy of what we're going to talk about today. Now, stage 3, the middle stage, which is constitute like 30% of the patients, about a third of the patients, we did not know what to do with the patients who have a mutation. So these patients were treated with chemotherapy, radiation therapy, and then they may get immunotherapy after that, even if they have the mutation, the EGFR mutation. Now, this study addressed this issue. Because these patients, while we were treating them for curative intent, actually, the 5-year survival is 30 to 40%. So we have a big gap that we need to address. Here will come the LAURA study, which was presented at ASCO plenary session, this year. So basically, patients who have this mutation, the EGFR mutation, after they get chemo and radiation therapy, if they have disease under control, they will be maintained. They will be started on osimertinib, which is a pill taken by mouth, for duration of the disease control. So the study was randomized patients, basically flipping a coin, Patients goes into the osimertinib, which is Tagrisso, or they go into placebo.
You know, I jump in just a
Go
second.
ahead,
So, yeah,
please.
sometimes people get worried about this placebo business. You know, they go, "Oh man, why would I be on a trial when there's half people are getting drug and the other half are getting nothing?" But the key here is that really the standard of care in these folks, because we know that chemotherapy in this setting so after that chemo radiation that you give together, chemo doesn't work very well. And there's a subset of trials where immunotherapy in these EGFR mutated patients doesn't really work very well. So the standard really was to just watch them. So don't be nervous when you hear, "Oh gosh, why they were giving these people nothing." It's because of this reason. The standard was nothing. And this seems to be perhaps a new standard.
Well, and it's not technically nothing. So to completely clarify, the one arm of the study, the patients got chemo and radiation, and then the placebo, which was observation. The other arm of the study got chemo, radiation, followed by osimertinib.
Correct. Yeah.
So everybody got the chemo and radiation
Yes.
in these stage 3 patients, but the kicker was those
do you do
patients.
afterwards?
What do you do afterwards? Because in this specific population, we weren't seeing a lot of things that were impacting the recurrence-free survival in that mutated patient.
Yeah.
Yeah, but they did a couple of smart things in the study, actually. The way they did it, they randomized 2-to-1, mean 2 patients got the drug and 1 patient
They had a
got
hunch,
the
right?
placebo.
They had
Yeah.
a hunch it would work.
Yes, that's number 1. Number 2, the second thing, that every patient who progressed has access to the
Crossover,
treatment,
yes.
crossover, and more than 80% who got the placebo end up getting the drug anyway. So that's the second move. The most important thing, this was called double-blind study. Double-blinded study mean neither the doctors know what the patient is getting, nor the patient should know. And that is one of the best study to compare between drugs and nothing, and doing the standard of care. This is not nothing, actually. The patient, as Andy and Jill said, they got the standard of care, which is chemo radiation therapy. And we know that immune therapy does not work in those patients who have EGFR mutation. So they basically got the standard of care. So,
And
this was one of the best results, in oncology history. Actually, the Dr. Suresh Ramalangam got standing ovation when he presented it. Actually, the progression-free survival of patients who got the osimertinib was 39 months, almost like 40 months, while those who got the placebo was 5.6 months, less than 6 months. So almost 7 times the duration of progression-free survival. And what we calculate the progression-free survival from the time that the patient start the treatment till the disease progress, mean you are able to control the disease for longer duration, almost 7 times than the placebo. And there is a risk reduction by 84%, as they say, in the benefit of getting the drug. So basically, you are extremely successful in controlling the disease for a longer period of time when you get the osimertinib if the patient has.
And I thought what was interesting also, they kind of mentioned this at the very end, is that there was a trend towards overall survival advantage, even though those folks who were on placebo were able to switch over. So they ended up getting the drug anyway, but the folks who were on the osimertinib from the get-go, there's a trend towards them doing better from overall survival standpoint.
Yeah. So this is, overall survival mean how long the patient lives, how long they live irrespective of the cause of death and so on. But, I would not be, disappointed even if the overall survival did not change, because the majority got the drug and they may benefit from it. But the bottom line now, this is becoming the standard of care, and everybody who has the mutation, you don't have to worry about the placebo. You're going to get the standard of care anyway, which is the osimertinib. So the study helped us answer the question, Now, we know what to do with the patients across the continuum and stages of lung cancer if they have the EGFR mutation. The take-home message now, we know patients with any stage lung cancer should have genetic testing to look for this mutation and, of course, other mutations for other stages.
Yeah, no, this is the essence of what precision oncology is really. So, you test that tumor for what it is, and you really follow almost a recipe book to say, oh, if you have this EGFR mutation, you need to get this drug. You don't have mutation, you need to get another set of drugs, or you have another. Those are what lead, and that's the whole essence of precision oncology.
Precision oncology helps give a very well-defined algorithm for each patient. Even
with the same disease.
Exactly.
Right?
So let's break down exactly who this study benefited. So we had lung cancer patients.
So non-small cell lung cancer patients.
That were non-small cell lung cancer, adenocarcinoma.
Correct.
Who were stage 3 and had the EGFR mutation.
Yeah, so stage 3 unresectable. Yeah.
Okay.
Yeah, but just I want to clarify, adenocarcinoma actually is the most common cancer to have this mutation. But if you look at any study, you'll find always few percentage that who are non-adenocarcinoma were tested and they are EGFR mutation. And I think in this study there were like 5%.
Were there some squamous cells that had that?
They call it non-adeno because they lump the large cell and other unknown and not significant, they lump them. So long they have the mutation and they are lung cancer, they are eligible to get.
And when we're looking at the big bucket of lung cancer patients, how many typically have the EGFR mutation?
Usually for adenocarcinoma between 15 to 20%, between 10 to 20%, so could be 1 out of 5 having this mutation. So it depends, sometimes may be less than, but that's usually the known range. Of course, it depends on the ethnicity. In the Asian, it could be reaching 40, 50%, but I'm talking about the American population is around 10 to 20%.
Perfect. Anything else?
I was going to say something, but I forgot.
You forgot?
No, I was going to say something from way back when Dr. Jazieh was explaining about lung cancer and talking about diagnosing lung cancer, just touching a little bit on screening.
Mm-hmm.
So the earlier and we talk about this all the time with breast cancer, right? So there's mammograms, MRIs, all these different tests for breast cancer. Same with colon cancer. We say, okay, you get your colonoscopy, at age 45 to 50 to get that first one, and then follow the recommendations after that. There are recommendations for lung cancer. So they're a little bit convoluted. So if you're a smoker or a previous smoker, see your doctor and they can help talk you through that. But you should be getting screening. Mm-hmm. The earlier you find these, the better off your survival is. So that was my 2 cents on.
Yeah, I will add 2 more cents.
Okay,
it's better not to get lung cancer at all.
Better not to get it at
all.
all.
To get lung cancer at all by not smoking, not to start smoking to start with. That's number 1. And if you are a smoker, stop immediately because the risk for lung cancer decrease significantly with time. But also I want to alert that if you are non-smoker and you have any symptoms or any shadow showed in your lung and so on, please do not ignore it and say, oh, if the doctor told you you do not smoke, you are not going to get lung cancer. That's not necessarily accurate. Take any shadow in the lung seriously and pursue it. Or any symptoms that does not resolve within a short period of time, make sure that you get checked.
Perfect. So it was exciting to share some of the lung cancer data that came out of ASCO this year, especially on World Lung Cancer Day. So I would like to invite everybody to tune in next time for our next Medical Minute. And until then, we will see you.